అయితే ఒక్కసారి చాయ్ తాగేసారా? మంచిది నావి. Good morning, dear students. Hope everybody is doing well, staying at home and relaxing at the same time. Try to study and enrich yourself with some knowledge. And today we'll deal with the tumors of the nose and sinuses. Actually, tumors are the ones, the tissues wherein there is a multiplication of cells which is purposeless, and they keep on multiplying even when the source of stimulus, whatever is the stimulus which started it to multiply, has stopped. It's a purposeless. So that is what a tumor is. And we have the nose and paranasal sinuses. We also have certain swellings which are actually not very, they're not tumors, they're not neoplastic, but still we also consider them and try to understand how these behave and the methodology of identifying, diagnosis, and then the management of these swellings in general and tumors in particular. Now, once again, we go back to the basic anatomy. Basic anatomy of the nasal cavity. How it is like a box, and the various paranasal sinuses, the maxillary, the frontal, the ethmoidal, and the sphenoidal sinuses, the bony cavities in the skull, are connected to the nasal cavity in the same type of mucous membrane almost. The pseudostratified ciliated columnar epithelium, which lines the nasal cavity as well as the maxillary, the various sinuses. So the anatomy is important because whatever disease that occurs is the one which changes this anatomy, and then by change of this anatomy there is a change in the physiology, the function, the basic function of the, for example, the nasal cavity. What is the nasal basic function? The function is to is for the breathing in and breathing out air, the olfaction, the temperature regulation, the humidity, the filtration, and sensation of smell. All these are all the functions. And when there is a disease which alters the anatomy, it also alters the physiology, basic physiology, all these functions. And so we try to study them by what are the various consequences of these tumors or swellings that occur in the nose and the paranasal sinuses. Now, broadly they are classified into three categories. One is the congenital, which are present since birth, and the other ones are the benign, where the tumors of this grow very slowly, but they are also they have a propensity to become malignant. And third variety is the malignant, where there is rapid multiplication of cells, purposeless, and which interfere with the various functions of the nose and paranasal sinuses. Then we will briefly go through these congenital conditions, which are not actually the tumors. These are usually grouped under the dermoid cyst, dermoid cyst, and you have this glioma, which is nothing but the brain tissue which is present not in the intracranium but comes into the nasal cavity. Then the encephalocele, that is the meninges, come into the nasal cavity by small defects that occur in the either fibriform plate or in the foramen cecum, and then come into the nasal cavity. So let's first briefly understand about the dermoid cyst. Dermoids are present in the situation where the mostly in the midline, where the fusion of the ectodermal elements they get submerged and they give rise to these kind of dermoids. So and basically they are usually classified as the midline swellings. Sometimes they have an external opening. If they have a external opening, they either, when they get infected and there is a small connection, which is called a sinus. So simple dermoids, they don't have a connection or a defect in the skin. They're just subcutaneous swellings, whereas the dermoids are the ones with the cyst and sinus. When the cyst ruptures, the sinus forms. Sinus is nothing but it's not the paranasal sinuses. This is a sinus where there is a long track. There is a small opening and then it leads into a track. So that is what a sinus is. Now these are usually seen in the children and in the region of the frontal bones, and there is a swelling associated, and this is how it is. Now this is the midline, the nose, the bridge of the nose, and that is the small opening through which sometimes some kind of a discharge keeps coming out. And you have the hair. Now this is usually associated with a swelling inside the dermoid, and this is a simple dermoid where the skin is intact, whereas this is the one dermoid with a sinus. So this gets infected and keeps on discharging continuously through this small opening into the skin. So these are the dermoids, and the treatment is simple excision of these dermoids right from the entire track and also the base. Okay, that is the treatment of the dermoids. And let me tell you, these are not tumors. The second one is the glioma. Glioma is nothing but the brain tissue outside the intracranium, and this is usually formed because of the failure in the dural membranous process, wherein the seal is not proper, and so there's a small amount of brain tissue which comes into the nasal cavity, and these are usually either extranasal or sometimes intranasal. Okay, and they usually mimic, because they're also in the midline, mimic the dermoid cyst, and usually by the texture we can find out that these are this is the diagnosis of the glioma can be made. And the other differentiating swelling is the encephalocele. I will tell about the encephalocele a little later. And the treatment of this glioma is once again the excision. And this is what a glioma is. See, that is the brain tissue proper, and that is the dura, and sometimes it is attached to the dura there, and that is one which is coming on to the nasal bridge. See, and sometimes it is intranasal, and radiologically you can easily make a diagnosis. And Then we go to another third condition, which is also not a tumor. This is nothing but herniation of the meninges along with sometimes the brain tissue. This is called encephalocele. The characteristic feature of this encephalocele is that it will when the child cries or coughs, there is an increase in the size of the swelling, because this is the one which contains, that is the dura mater, the pia mater, how it herniates through that, and you have the CSF in this. So this is also radiologically you can make a diagnosis, and then the treatment is, once again, this is the nasal. Okay, there is a defect there, and then from there the encephalocele is presented into the nasal cavity. So with that, those are the congenital conditions which are present. They are swellings but not tumors. Now we come to the tumors problem. The benign tumors. Tumors are usually divided into benign and malignant. The benign tumors are the ones, the epithelial origin and mesenchymal origin. Epithelial in the sense, the mucous membrane which is lining and the skin, all these are the epithelial tumors. Whereas the soft tissues below are the mesenchymal tumors. These are usually, if they are arising from the bone, they are called the osteomas, and various other fibrous tissue and fibrous dysplasia, the fibromas. And if they are arising from the vascular elements, they are called the angioma and juvenile angiofibroma, as we have studied in the last class. And then the odontogenic tumors, odontogenic in the sense something related to the odontomes, that is the teeth, development of the teeth, and they are usually the dental cysts, the Dentigerous cyst. They are cysts, they are not tumors, but Ameloblastoma is the one which is arising from the periodontal membrane, and they form this tumor, Ameloblastomas. Then you have the tumors which are arising from the nervous tissue and neurogenic tumors. And where is the nerve supply? Usually these are related to the olfactory epithelium, the olfactory nerves, which are situated almost at the roof level and above the superior turbinate. So let's try to understand what is simple papilloma, which are usually called maybe warts. They have small peduncle, usually situated anteriorly, and the treatment is you just have to from the root you just remove these papilloma and then maybe cauterize that small area. So that is the treatment as far as the simple papillomas are concerned, which are usually present in the anterior part of the nasal cavity, which is lined by skin. That is the vestibule, which is otherwise called vestibule. Then we go to another interesting condition which is present in the nasal cavity, which is called the inverted papilloma, which is otherwise called Ringet's tumor or Schneiderian cell papilloma. These are the various synonyms that are given to that. Now, the inverted papilloma, as the name itself suggests, that this tumor is the one wherein the mucosa is the one which enfolds inside and with an intact basement membrane, and so it's a peculiar. Usually the papillomas are the ones which are exophytic, which grow like that, but this is the one where the mucus enfolding of the mucosa occurs, and so they are a little peculiar as far as the and they also behave sometimes peculiarly, because they almost behave as if they are locally malignant, and there is always high transformation of these inverted papilloma into malignancies. Okay. Then so this is basically a benign tumor which is usually seen in the age between 40 and 70 years. There is a male preponderance, and usually they are almost always unilateral, one-sided. The clinical features, as you know, when there is a tumor or a swelling which is present in the nasal cavity, the first thing is obstruction. And because it's a tumor with vascularization, and so there is a small rupture of these blood vessels which are feeding this tumor. There is epistaxis. Okay. And since they block the air passage, sometimes anosmia, and they block the sinuses, so we get a headaches. And these are the various clinical presentations of this. And when you examine, on examination, they look soft pinkish fibril mass which bleeds on touch. And these are usually classified because they are peculiar, not like the other tumor, papillomas, because they are locally infiltrating. So they have classified, and the Krauss staging system, just remember, it's not very important, but if it is confined to the nasal cavity, it is T1, and T2 is osteometal complex region, ethmoid, or medial maxillary involvement. Okay, that is the T2, and T3 is any wall of the maxillary sinus. You have the various medial wall, lateral wall, anterior, posterior, inferior, and superior. These are all walls. It's like a chamber. So any wall, that is the T3, and extra sinus, if it is gone beyond the sinus, it is T4. Usually such are the ones which are usually transformed into malignancies. Now this is how they look. This is the endoscopic picture of a left-sided nasal cavity with this tumor is protruding into the nasal cavity, and that is the middle turbinate, the inferior turbinate, and this is where it is coming from. See how it blocks the nasal cavity. And to make a diagnosis, it is usually the radiological and also the confirmation of this tumor is by histopathological examination, which is called nasal punch biopsy and histopathological examination. Now the treatment is a little aggressive than the regular papillomas, because it has got a tendency to infiltrate into the tissues and behave as if it's a malignant tumor. So the treatment is a wide excision by a lateral rhinotomy. Lateral rhinotomy is an incision wherein you cut open the nasal crease here and then go around and then split the lip and lift up this part of the nasal cartilages, and so you have space for you to go into the nasal cavity, and you can also lift this flap wherever there is requirement. And this is what it is. This is the left nasal cavity, this is the floor of the nasal cavity, this is the inferior turbinate, that is the middle turbinate, these are the ethmoidal air cells that are there, and so you have to remove the entire medial wall of the maxillary sinus and medial wall of the orbit, which contains the ethmoid, the air cells. So this is called a medial maxillectomy and en bloc ethmoidectomy. So this is the procedure which we need to do. This tissue, the fibromas, and the vascular, the hemangiomas, from the nerve tissue, it is neurofibromas, schwannomas. So these are all the various mesenchymal tumors. Now let us go into the osteogenic tumors, which are usually osteomas and the ossifying fibroma and fibrous dysplasia. This is another condition where there is a spongy bone that is formed with a ill-defined capsule, and it is not a malignant, it's not a tumor. Whereas osteoma and ossifying fibroma, these are the tumors, benign tumors of the nasal mesenchymal tumors. Now, first we go into the ossifying fibroma. This is usually these are present in the maxillary and ethmoidal sinuses. Okay, and the clinical features are, as you know, are the nasal obstruction, sometimes the headaches because they block the sinuses, and the examination is the X-ray of the paranasal sinuses, basic, and the CT scan. The histopathological examination, as I told you, consists of spindle-shaped fibroblasts, which are arranged in world-shaped pattern, small islands of metaplastic woven bone. So there are both the elements that are present, the spindle cells of the fibrous tissue as well as the bony tissue, the osteogenic, the metaplastic woven bone. That is the histopathology. With that, we identify the extent of the tumor and excision, because it's a benign tumor. Excision of this tumor is the treatment of tumors. Then the osteomas. These are osteomas which are the benign tumors of the bone. Usually they do not produce any symptoms, very rarely. These are usually identified when there is a routine X-ray that is done for some headache for the nose and paranasal sinuses. These are more common in the frontal sinus. They don't produce any symptoms until they block the sinus openings, that is the frontonasal duct. So when there is no symptom associated with that, you don't need to do anything. But when there is an obstruction to the sinus outflow, which is leading to the infection of the sinuses and sinusitis, giving rise to headaches, then that is the time we need to remove these bones. The excision is the treatment of choice, and these are the ones which are, as I told you, accidentally seen when some X-ray was done for the sake of some another problem with which the patient comes to you. And this is another condition which is called fibrous dysplasia. As I told you, this is not a true neoplasm, and it consists of the spongy periostal bone with a thin cortex and ill-defined edge. These are usually simple ones are called monostatic, which is local. Sometimes they are diffuse and they involve several facial bones and cranial bones. Usually they involve the maxillary and ethmoid bones. The problem with this is on one side it will be there's a deformity. There's a bulge there. Okay, there's a bulge, and most of these they grow very slowly. And the reason for removal of these fibrous dysplasias are more cosmetic. Okay, so only cosmetic purpose the removal excessive growth is taken. So these are the fibrous dysplasias, and then we go to the angiomatous, that is the vascular related tumors. The fibroangioma of the septum is the one. And angiomas are the sinuses. Angiomas are vascular tumors. So vascular tumor, the treatment, the clinical signs are usually because of the obstruction. They produce the nasal obstruction and headaches, but predominantly they present with bleeding from the nose, which is called epistaxis. And sometimes the angiomas, which are situated in the sinuses. And this is a angioma which is attached to the septum. This is the septum here, and that is the nasal vestibule. And so usually they are pedunculated. So you remove the tumor along with the peduncle and some amount of mucoperichondrium that is present on the nasal septal cartilage and remove that and maybe cauterize that area. That is the treatment of choice. And radiologically, this is how you confirm the tumor. So these are benign tumors of the vascular elements. Then that is what is the angioma of the septum. Then the angioma of the sinuses, which are there in the maxillary and ethmoidal sinuses, they usually manifest and presentation is usually epistaxis. So the diagnosis is radiological diagnosis and treatment is once again excision. And if these tumors are bigger then and more vascular, which can be known by carotid angiography, then we need to do a pre-embolization, just like the juvenile angiofibromas, embolization, and or earlier, before this embolization technique has become popular, we used to go into the neck and temporarily tape the external carotid artery, because the major supply of that is from the external carotid artery, particularly the sphenopalatine artery, which is a branch of the maxillary artery. So with that preparation, embolization, or if it is very vascular, temporarily you just block the carotid artery, put a tape around that carotid artery. Once the surgery is over, you can remove the tape, and this is how you can reduce the amount of, just like applying a tourniquet for orthopedic surgeons. So this is what is done for the angiomas of the sinuses. And then we go to the odontogenic tumors. And as I told you, the odontogenic tumors are related to the teeth. So the basic simple cyst, dental cysts, which are usually present at the tip of the root of the nasal, root of the tooth, from the periodontal tissue or the membrane, and the small cysts that are formed, they are not tumors. And Dentigerous cyst is a follicular cyst. This is usually arising out of the non-erupted tooth, the follicles around that, and there is a slowly enhancing, and it makes the bone very thin, and you have these eggshell crackling kind of a sensation when you press on them. So these are called the dentigerous cysts. A dental cyst is a simple cyst, okay? Whereas the dentigerous cyst is from the retained unerupted tooth, from the follicle around that, and these expand gradually without pain and unless infected. The deformity depends on the position of the cyst, the eggshell crackling, as I told you, and the treatment is removal, or if it's a big one, marsupialization. This is how radiologically, this is the tooth which is not erupted, and so it's something like a cyst-like thing. Okay, so that is a dentigerous cyst, and it is not a tumor once again. Ameloblastomas. Ameloblastomas are once again the tumors which are site of origin is the periodontal membrane, epithelial lining of the periodontal membrane, and the tumor starts in the cancellous bone and grows slowly by extension into the marrow spaces and producing entire bone resorption. They are very slowly growing, but when they grow, there is a tooth which is in which they are related to. The tooth becomes loose, and this is how the ameloblastomas, that is, and sometimes they become, when they grow like that, there is an ulceration there, and if you see them peroral, see, this is the swelling that that is present. So radiologically, this is how it looks like, and the treatment is once again the excision of this tumor. Then we go to nerve-related, that is the neurogenic tumors, and as I told you, the neurogenic tumors are usually arising from the olfactory epithelium, which is in the nasal cavity, which is present almost at the roof and above the superior turbinates and corresponding area onto the septum. So these tumors are the ones, this is what the radiologically, that is the area where they grow. And these tumors are the ones when they rapidly grow, sometimes there is an ulceration, and these tumors are unilateral, but they keep on spreading like that, and by the time these tumors sometimes can become malignant. Then we go to the malignant tumors per se. These are the squamous cell carcinoma, particularly the maxillary sinuses or the ethmoidal sinuses. The lymphomas are the next ones, and melanoma from the pigment cells, and of course the adenocarcinomas. These are the various malignant tumors that are present. And the squamous cell carcinoma is the commonest. The other tumors are not very common. So the squamous cell carcinoma, as you know, the nasal cavity is lined by pseudostratified squamous epithelium, pseudostratified ciliated columnar epithelium, which is called respiratory epithelium. And because of the chronic infections, either smoking or repeated infections, there is a transformation of this epithelium into squamous, the pseudostratified ciliated columnar epithelium, which is called the respiratory epithelium, is transformed into squamous epithelium, which is called metaplasia. And usually the squamous cell carcinomas are the ones which are present in the maxillary sinus. Lymphomas are, as I told you, the tumors of the immune system, and melanoma are derived from the pigment cells, similar to those that cause the skin melanomas, cancers. Then the adenocarcinomas have been shown to be more common in those people who work with hardwoods. Okay, so the squamous. Then we go into the squamous cell carcinoma, which is the most common of these malignant tumors, and the incidence is roughly about 1% of all malignancies, and they constitute about 3% of the head and neck malignancies. The viral infections are incriminated to Epstein-Barr virus and human papilloma virus, because the antibodies are present for this, and exposure to certain chemicals and post-irradiation. So these are the factors which influence the initiation of these squamous carcinomas. Now, clinical features, as you know, the nasal deformity, unilateral nasal obstruction, blood-tinged nasal discharge, epistaxis, hyposmia. This is how the tumor alters the anatomy and then produces all these interference with the normal physiology of the nasal cavity. And this tumor from the maxillary sinus can spread into the oral cavity, destroying the hard palate and come into the mouth. And this is how it is. See, these are the upper teeth, this is the palate, and so from the maxillary sinus, if the tumor spreads into the oral cavity, this is how it looks like. Then it can spread into the nasal cavity, or it may spread anteriorly. Into the skin or the cheek. So this is how it looks like when it comes to the front, anterior wall. And if it is presenting into the nasal cavity, it can go into the nasal cavity, and so this is how the tumor looks like, and producing deformity of the nasal pyramid and obstruction. So this is as far as the end. It may spread laterally into the pterygoid spaces and retromaxillary areas also, and then it can go superiorly into the orbit. It can go into the orbit and produce deformities of the maxillary orbit and displacement of the eyeball. Then they can also project or spread via the cribriform plate into the frontal lobe. So the intracranial spread, where when there is a destruction of this, then you have the CSF leak and headache. So these are the various ways in which the maxillary carcinoma spreads into various, into the, as we have seen, into the oral cavity, into the nasal cavity, anteriorly into the cheek and the pterygoid areas which produce. So depending on the various infiltration or the mode of spread of the growth, the various symptoms are produced. Now it can go into the orbit, and it can go into this. So these are the various ways in which the tumor spreads, and the basically radiological investigations, and of course the biopsy is the one which confirms. Once the diagnosis is made, then you have these classifications. These classifications help you to understand the prognosis in the sense how the tumor behaves. So Ohngren is the one which described a line drawing from the medial canthus to the angle of the mandible. The tumors which are present anterior-inferiorly have a better prognosis. Okay, infrastructure, good prognosis. Whereas the tumors which are behind this Ohngren's line, because they involve the ethmoids, the orbits, the cribriform plate, so and the sphenoids, their prognosis is bad. So there is another classification which is called the Lederman's classification, where this is the orbit, and that is the crista galli and the ethmoidal air cells, and that's the middle turbinate, and that is the floor of the orbit, the floor of the orbit. So a line drawn along in the line of the orbit, floor of the orbit, and another line drawn at the floor of the maxillary sinus, floor of the maxillary sinus. This divides them into three compartments. The first one is the ethmoid, sphenoid, frontal sinus olfactory area of the nose, where the prognosis is bad. The maxillary respiratory, this is the second one, and third one is the alveolar. So this is the Lederman's classification, and then you have the regular AJCC classification by the tumor board of the American journals, and wherein you have the staging T1, T2, T3, T4, A and B, and these stage 1, 2, 3, 4, stage 1, stage 2, stage 3, stage 4. So this is how any of the tumors, malignancies, are classified by this kind of a classification: tumor size, and then lymph node size, lymph node involvement, and the final staging. So after the staging is done, we have the various protocols that are described. For each stage, there are certain kinds of protocols that are followed, wherein the results are the best. The modes of treatment for these any malignancy is the surgical, radiotherapy, and chemotherapy. These are the modalities of treatment that we have as far as the treatment is concerned. And malignancy treatment is usually the surgery. Now, whenever there is a possibility of a removal of these tumors, surgery is the best, because at a single stage you can remove the entire tumor. So the various incisions that have been described, one of the popular ones is the Weber-Ferguson incision, wherein it starts from just below the medial canthus, comes down along the lateral side of the nasal pyramid, and then encircling the lobule, and then comes to the center and splits the lip, splitting of the lip. And then you raise the flap, and if you want a little extension into the up to the zygoma level, then you give an incision infraorbital extension. And if there is further requirement, it can be further extended. Ultimately, the flap is elevated, and that is the incision in the inferior margin of the orbit, and that is the infraorbital foramina. And so this part of the bone is exposed, and then in a maxillectomy, this is the orbit, this is the ethmoid bone, which forms the medial wall and lateral wall of the nasal cavity, and this is the inferior orbital rim, and that's the midline, and that's the pterygoid area, that is the zygoma, and make an incision there, and then you remove the entire tumor and block, and then it is reconstituted by the plastic flap that is being given, and that is the treatment of the maxillary malignancies. Okay, so that in general, the various masses of the nasal cavity. Some of them are congenital, which are not tumors, but we have dermoids and encephaloceal gliomas. Then you have the benign tumors, the papillomas, arising from the epithelial. Then you have the myxomatous from the subcutaneous tissues, mesenchymal, which are from the bone, the osteomas. Then you have the fibrous tissue, fibromas, and neurofibromas from the nervous tissue. Then you have the vascular, the hemangiomas. This is how they have made a diagnosis, make a diagnosis and then treat. Thank you.
Oh.